I'm Mark Hardy. I'm Auchincloss Professor of Surgery and founder of the Transplantation program at Columbia. Dr. Karin Hahenberger is CEO of Lyfebulb. Dr. Gerald Appel is Professor of Medicine and Director of our Glomerular Disease Center. And Dr. Ali Hussein is Assistant Professor of Medicine. Dr. Maya Rao is Associate Professor of Medicine.
Welcome, everyone. We're very excited to have you here today. We really want to answer your questions about living with end-stage kidney disease, how to prepare for the next step, which in many cases dialysis, and of course also transplantation.
You know, if you're a patient out there and listening to this, you're not alone. 15% of all adults in the United States have chronic kidney disease. That's 37 million people, one out of every 7 people. And close to 150,000 people started treatment for end-stage kidney disease last year in the United States. It's 150,000, huge numbers. There are something like 750,000 people now living on dialysis or with a functioning transplant. The most common causes, by the way, are hypertension, diabetes, and inflammation of the filters, glomerulonephritis.
The general recommendation is that you start preparing for dialysis when the kidney function is around 20% or less. And that really is because we want people to have all the options in terms of home dialysis, whether they want to do dialysis in a center or not. And in order to make those different options happen, we have to be able to plan for it. In terms of when a person would actually need dialysis, you know, there's never been any study that supported that starting early dialysis is beneficial. But again, the preparation does take quite some time, and there's a lot of decisions people have to make in terms of what fits with their lifestyle. And so in that sense, we do usually start talking about these things once the kidney function gets to about 20%.
Yes to everything. I think kind of talking about all of those options is important, because there's no clear evidence that any of those modalities is better than any of the others, but they offer a lot of very different benefits and downsides. So kind of being able to explore all of the different possibilities allows someone to find the fit that's best for them. So for example, some people who we take care of just say, I don't really like to be very hands-on in my treatment types. I'd rather show up to a center and have the treatment done to me and leave, and that's it, right? But some people say, I like to live a very active lifestyle. I like to travel a lot. I like to travel internationally. I have very long work hours. I'm not able to reliably attend an in-center session. Having adequate preparation ahead of time allows you to start with your preferred modality. And I think a big place where we go wrong as a nephrology community is that a lot of people end up starting by default, the vast majority of Americans actually, on in-center hemodialysis, even though if you kind of poll people on what they would like to be on, it's largely not in-center hemodialysis. Dialysis in general, you should think about as kind of artificial replacement of part of the kidney's function, which is the function of cleaning the blood. Each kidney has about 1 million filters in it, and basically blood flows through those filters every second of every day and removes toxins and holds on to things you need, like salt and water and some other electrolytes. We can either do hemodialysis, which is when blood is removed from the body, passes through a machine, and then kind of the clean blood is returned back to the body. For peritoneal dialysis, we leverage the body's own membranes, or kind of a thin film inside the abdomen. We instill some kind of special fluid into the abdomen, let that cleaning happen across the body's own membrane, and then take the fluid back out, and with it, some toxins and other materials that we'd like to remove.
Education is absolutely key, and a patient is their own best advocate. And in a way, we're trying to individualize the treatment to what their goals are and their lifestyle is. The physician can't know that. We need to hear from our patient. The peritoneal dialysis is such a great option because it allows people to have flexibility with travel and also to be home. Often can be done mostly at night. It's a catheter that goes into the belly, a soft catheter. And that's something that we can put in a few weeks before we start the dialysis, but there's also a training period of about 2 weeks. With hemodialysis, ideally, we want a patient to have a shunt put into the arm, either a fistula or a graft, and that's done by a vascular surgeon. A fistula can take a couple months to, after the surgery, when we can use it, it has to get big. We call it, it has to get matured. So we need even more lead time for the hemodialysis, ideally. So this is why early discussion is so important. And I'll say, as somebody who takes care of lots of patients transitioning to dialysis, I think one thing I see, and it's totally understandable because this is a traumatic and difficult transition for patients, is this sort of denial, not wanting to face it, but facing it and really understanding what your options are is the most important thing, so that your doctor can kind of help you decide what's going to be the best plan, ultimately with the goal of getting a transplant always. I'm selfish because I always want my patient to get the kidney. I'm not on the side of the transplant like Dr. Hussein, so conflict of interest. But I always tell my patients who are worried about this, oh, I don't want my family member to donate. I wouldn't want them to end up with this. And what I say to them is the transplant center will never take a kidney from somebody if they feel it's unsafe. Their obligation first and foremost is actually to the donor. So, there is absolutely extensive testing and a very rigorous process to make sure that the patient who is giving the kidney doesn't have any underlying kidney disease, any risk for kidney disease, and therefore they would be safe to donate the kidney to the recipient.
The body has a lot of reserve in the kidney function. And if we can kind of do extensive testing and find a well-selected donor whose risk of kidney complications later on in life is low, the overall risk is really low. So we know that lifespan for donors and non-donors is the same. So we don't think it has any impact on how long you live. And then going farther out in terms of long-term effects on risks of things like high blood pressure or protein in the urine, those risks are probably slightly higher for donor compared to if they didn't donate. But overall, probably that effect is low. And it's never been shown that those actually kind of correspond to other problems that we actually care about more firmly, like a higher risk of heart attack or stroke, the reasons why we care about high blood pressure. And then finally, in terms of risk of kidney complications long-term, so probably just over 30 out of every 10,000 donors will develop kidney failure. And probably many of them might have developed problems even if they never donated.
I have patients now who are over 40 years post-transplant. I have a fair number over 30, 35, and many, many who are over 25. I've only had one patient that I've taken care of in my entire experience who made it over 25 years on dialysis. Dialysis, even though it's the best effort, we're getting better and better. It's cleaning the blood. We have to provide the hormonal therapies, and there are probably 1,000 things we don't know that the kidney actually does that makes a difference. You just cannot match kidneys in terms of by dialysis. So if I had the choice in a family member or myself, overwhelmingly, unless there was some strong reason not to, I would opt for transplant. And I tell my patients that. I mean, if somebody is 95 years old and they have cancer and a bunch of things, they may not be a great candidate for a transplant. But, for younger people, for people with glomerulonephritis, which are largely a younger group, always it's transplant.
The hemodialysis, if you have a catheter inserted, that is absolutely the highest risk of infection. And that's why we do not want patients to have that, or if they do, very limited. The fistula in the arm, the shunt, has a much lower risk of infection. But the peritoneal, you are taught really sterile technique and how to keep things clean. That's a main part of the training, actually, is learning how to keep everything clean, be in a clean room. And if people follow that, the risk of infection is actually exceedingly low. And, if you do get an infection, you get antibiotics, but the overall risk of infection in PD is not higher than hemodialysis.
terms of what you can do in dialysis, you can work, you can play sports, people go on hikes, people run marathons, they do big bike races. Really, there's nothing that you are absolutely unable to do. Just kind of finding the best way to accomplish each one of your goals by working with your team and providing the therapy that can kind of best align with those goals. People work all kinds of different jobs on dialysis. People do all kinds of activities. They play high-level sports. And I think another great thing to do is to talk to others in the kidney community. And I think that's why having support groups and forums are so helpful, is that, I think that most kidney patients shouldn't take no for an answer. They really want to do something, and a doctor saying it's not possible, because there's very few things that actually are not possible. Some are. But, if you say, I really want to get back to hiking, and your doctor's telling you, no, you can't, or I really want to travel, and your doctor's telling you can't, get a second opinion, get a third opinion. And this comes up all the time. I know we're not talking about transplant, but with transplant, people will be told, you're not a great transplant candidate. You might be too old, or you might be too sick. You might not have enough support. But plenty of times those patients go to get a second or third opinion at a different center, get transplanted, and do very well. And remember that a lot of these decisions are subjective, and kind of finding the doctor whose values kind of align with yours and who kind of understands what your preferences are is very, very important in making sure you can maintain that functionality.
If it's less than a gram of protein or a certain amount in the urine, most people would not recommend a biopsy, but just trying to treat it non-specifically with certain blood pressure medicines, other medications, and slow the course, because you would not use immunosuppressives regardless of what disease it is. Now, if it's over that amount, usually a biopsy is done. That's true for the United States and most westernized countries. On the other hand, some countries biopsy earlier. In Japan, they use half the amount and they would do biopsies to diagnose what's going on. So it's dependent on the patient and whether they have other findings in their body that suggest arthritis or eye disease or something that suggests there's a disease where you can make a diagnosis such as lupus, amyloid, or something else by the kidney biopsy. So not everybody with proteinuria needs a biopsy.
It's not likely, it happens, but again, whether that has to do with the kidney failure itself affecting fertility or the dialysis itself, and also taking a person through a pregnancy while they're on dialysis is also quite challenging. We have to increase the frequency of dialysis quite a bit. So it's not impossible, but it's unlikely. It definitely affects fertility. Chronic kidney disease itself does affect the outcomes for the fetus and also for the ability to carry a fetus to full term. So a person has to understand the risks, but at the same time, it's difficult because if your GFR is 25, no one's going to put you on dialysis or a transplant list. So therefore, it gets complicated in terms of whether you can wait to get a transplant and get pregnant after, which is another whole thing, or not. So I think it's a complex question, but I will say that having chronic kidney disease does affect pregnancy outcomes and outcomes for the fetus.
It requires a great deal of discussion with the nephrologist and the gynecologist both.
Yes, and coordination.
But transplant, on the other hand, is certainly, for getting pregnant is not a problem. Once somebody is stable on transplant, whether you want to recommend 6 months, a year, 2 years out before, but most people would say after a year. I have a little scrapbook full of pictures of children that have been born after they were transplanted. It is now a full scrapbook. I've watched the kids grow up. The kids are college age and almost adults now with their pictures with their parents. You just couldn't think of that.
I think most nephrologists or most transplant physicians would not advise women to get pregnant because they would need to get off their immunosuppressives or at least switch them.
But we do that all the time. I do that all the time. I don't know how many we've gone through, but some of the ones like the calcineurin inhibitors, like cyclosporin and tacrolimus, can be used during pregnancy. Steroids can be used.
If you look at transplant, despite those medication changes, despite the physiologic changes of pregnancy, their outcomes of transplant are the same as women who never got pregnant. So I think that everyone does get nervous,
that's
especially
early. That's a great message to give to our audience. We've had that conversation on Transplant Life, and many of the young women who have been conversing around this have been very, very frightened by their physicians. So that's wonderful to hear that. And I think we should try to get that data out on our platform and show it to those women.
I think it's remarkable. In my lifetime, we've seen transplant go from a small thing where we could only do 20, 25 patients a year, and I'd come back from vacation and ask who was still alive. Now you can do hundreds and hundreds, and you expect them to do well with transplantation. And dialysis as a modality for younger people to get them through to transplantation, and for some other older people, is a good modality. I mean, these people are alive. When you talk about, 700,000, 800,000 people with dialysis or transplanted in the United States, alive now and functional, it's just remarkable.
There's so much has happened in the past 3 years, even, 2 new classes of drugs approved to slow the progression of kidney disease, new research on stem cells, artificial wearable kidneys, all kinds of technology that are really going to kind of help people maintain the kidney function they do have and give them great options to replace their kidney function as it deteriorates. I think kind of the future is very hopeful for kidney disease, and it's important to remember you're not alone. There's a lot of people dealing with the same thing, and kind of as a community, we can really help progress the quality of kidney care.
We have new drugs, and these drugs show mortality benefit. They're slowing the progression of kidney disease. That's exciting. We have several diabetic drugs that look like they're really slowing kidney disease down, and they have a lot of benefits. So I think it's an exciting time. I think there are new drugs that we have, and there's a lot of active research being done in things like wearable artificial kidneys. And so I think this is a great time for the nephrology community.